Dr. Om Ganda came and presented us a wonderful lecture on future of lipidology and how the global drugs are moving towards which direction of lipid movement. Today, the topic is today anemia in elderly. I take the pleasure of introducing our moderator who would be joining us soon, Dr. Sanjay Kalra. He is a DM endocrinologist from All India Institute of Medical Science, New Delhi, and is a consultant at Bharati Hospital, Education Working Group, International Society of Endocrinology, which is ISC. He is the president of Indian Professional Association of Transgender Health, which is IPAT. He is a section editor of our API textbook of medicine. In a senior section editor of Tropical Endocrinology, which is Endotex, the PubMed Index textbook. His hobbies are traditional Haryani Mudgar and Bhangra. I welcome Dr. Sanjay Kalra and hand over this session. Sir, welcome.
Thank you and good evening, everybody who is logged in on the show. It's been many weeks now, nearly 3 months of talking about iron. We've talked about different populations. But is there something we've forgotten? We've talked of children, we've talked of women, we've talked about diseases like cancer, metabolic syndrome, diabetes, obesity. But have we forgotten our senior citizens, our silver citizens? No, we haven't, because we are remembering them today. When we speak about anemia, we tend to think it is a disease of women, a disease of children. But actually, everyone can suffer from anemia. And that's why today we'll be talking about anemia in the elderly. And for this, we have an expert with us. Let's welcome Dr. Navneet Agarwal. Warm welcome, Dr. Navneet.
Thank you, sir.
Dr. Navneet is a physician and diabetologist practicing at Gwalior in Madhya Pradesh, a very dynamic name in the field of medicine and diabetes across the country. You can see from his CV, from his biodata, his work speaks for itself. But today, let his words speak for themselves. So, Dr. Navneet, warm welcome.
Thank you, sir. Thank you.
Dr. Navneet, you've been in practice now for 2.5 decades. So, what is happening to the age of your patients? The average patient, when we see the data from across India, we see that our population is growing older. Do you find that happening in your OPD as well?
Yes, definitely. Like what we see that even the patient, when I started my practice, like I was seeing them almost 20, 22 years back. And now these, like when I saw them and they visited to my OPD, they were in 30s or 40s or 50s. Now they have become 70s. So the aging of the population, which I was seeing for last 22 years, I'm seeing them aging with me also. And in fact, like the patient with the comorbidities coming to the OPDs in the elderly population, yes, we are seeing the increased number.
So, this tells us another secret about Navneet, and that is the secret of sustainability. How do you sustain a clinic, Dr. Navneet, and how do you make sure that people who were consulting you 2.5 decades ago are still coming to see the same doctor? That is a secret that we have to learn from you. So over to
That
you. We'd like to learn about anemia. We'd like to learn about geriatric medicine and also this secret that you've been hiding with yourselves, the secret of sustainability of and the secret of success. So over to you, Dr. Navneet. Thanks for being with us.
thank you, sir. Thank you for the nice words. And can I share the slides? Can I have the presentation, please?
Sure.
So at the outset, I wish to thank the Heart Foundation of India and the team FDC for giving me this opportunity and to discuss, as Sanjay sir was saying, the geriatric population. We are not forgetting the geriatric population, and we are going to discuss anemia in elderly. And we know that anemia is a very common clinical situation which we come across all the population, not only the elderly but across all the populations. And in this show, this has been already discussed, the anemia in the children's, in the women's, in the other population. And now my task is to discuss the anemia in the elderly population because it is an important healthcare concern among the elderly. And the prevalence of anemia, it increases with age, particularly amongst the oldest and the most frail population. Prevalence of not only the anemia, like when we talk of anemia, there are some population or some percentage of population which has this unexplained anemia of aging, which is also increasing with age. So this unexplained anemia is diagnosed by exclusion of known causes of anemia, and it is associated with decreased quality of life. So the anemia might have our elderly population to suffer from the reduction or the decreased quality of life, and maybe morbidity and the problems. So in our next 30 to 45 minutes, we'll be discussing about the prevalence of the anemia in the elderly population, its etiopathogenesis, then how to elicit the history to make a diagnosis, then what are the symptoms and signs, the what lab test or the investigation we should perform to diagnose correctly the anemia in this elderly population, and the differential diagnosis, and how to manage this anemia in this age group. So when it comes to the prevalence of anemia, we know it is common among older population, and globally, the prevalence of anemia in the patients who are in the population who's aged more than 60 years is around 39%. But when it comes to the Asian population, it may be around 54%. And if we see this, the anemia in the elderly population is around 12% in the community living. But when it comes to the nursing home or the hospitalized patient, the prevalence goes up to as high as 40% or 50%. As far as definition of anemia in this population is concerned, as per WHO criteria, hemoglobin level of less than 13 for men and less than 12 gram per deciliter for women is defined as anemia in the geriatric population. There are some different say recommendations about the thresholds for proposing anemia in the elderly, but the commonly followed is the WHO guidelines. But there are some like the Bittler et al. And the Entis et al. They have been based on the different cutoffs for the hemoglobin level in the elderly population. But commonly, this anemia of the elderly population, which we follow the definition, is of WHO. When it comes to the pathophysiology of anemia, it is complex and multifactorial. So if we talk of the etiology, it can be subgrouped or subdivided into the five classes. One is the nutritional deficiency. It may be a deficiency of iron. It may be deficiency of vitamin B12. It may be deficiency of folic acid. Then you have some bleeding disorders like the GI bleed, lower GI bleed. Then we can have anemias which are developing in the context of the chronic inflammations and in this chronic kidney disease. Then we can have a clonal anemias, maybe myelodysplastic or the clonal hematopoiesis. And finally, we can have an unexplained anemia, which is after the bone marrow examination, we label it as an idiopathic cytopenia of unknown significance with isolated anemia. So there are multiple conditions that may underline this unexplained anemia in elderly, like the undiagnosed myelodysplastic syndromes, clonal hematopoiesis of indeterminate potential, androgen deficiency may be a cause, impaired bone marrow response to the erythropoietin may be a cause, low-grade chronic inflammation, we call it as an inflammaging, and vitamin D deficiency might cause the unexplained anemia in the elderly population. And sometimes we may have unrecognized iron deficiency where the ferritin threshold higher than the classical, but the peripheral blood film will show the microcytosis will not show. So different diseases which are frequently associated with anemia in elderly population, we can see the in the chronic inflammatory disease like the rheumatological diseases, chronic infectious diseases, inflammaging, and the examples for such type of disorders may be like rheumatoid arthritis, chronic hepatitis, osteomyelitis, frailty, cachexia, geriatric syndrome, or even the chronic leg ulcer. Amongst the non-hematopoietic neoplasms, we can have GI tumors like the colorectal cancers, gastric cancers, multi-organ metastasis like the end-stage carcinomas, where we have the metastasis to the different organs, bone marrow metastasis like various cancers, which including breast and prostate, they metastasize to the bone marrows. Then we can have endocrinological and the metabolic causes, low production of erythropoietin, like the renal anemia or pure EPO deficiency. Then we can have the anemia with the thyroid dysfunctions, like the hypothyroidism or hyperthyroidism. We can have the insulin deficiency, like in diabetes. Then we can have a anemia due to blood loss, like the GI bleeding, diffuse GI bleeding, surgical procedures, or even different location bleeding, like the epistaxis or hematuria. Then we can have increased consumption or destruction of erythrocytes, like chronic non-mechanical hemolysis in the autoimmune hemolytic anemia, mechanical destruction of red cells, like the prostatic heart valves, or even hypersplenism. Nutrition, vitamin D deficiency like vitamin B12 and folate, trace element deficiency like the copper deficiency, and definitely iron deficiency anemia is still a challenge in all the populations. When it comes to the drug-induced anemia, chemotherapy may cause the anemia like it causes pancytopenia. Antimetabolites, anticonvulsant drugs might be associated with the folate deficiency causing anemia in the elderly. and toxic drug reactions like the drug induced hemolysis might be a cause. So whenever we think of different causes, or like when we are analyzing or assessing a patient workup, doing a workup of a patient of anemia, we should consider all these different situations wherein we can find the anemia in this population. As far as like when we have to work up or when we have to assess a patient of anemia, particularly elderly population, we should be very particular about taking the history, because a good history gives a clue towards the diagnosis of that particular patient. So we should be taking a proper history, particularly related to the bleeding, like per rectum or heavy menstrual bleeding, black cherry stools, hemorrhage. We should assess a thorough dietary history. What is like, because this population has the problem of dentures, they might not be taking the green vegetables, they might not be taking the different food items because of the loss of taste. So we should be having a proper dietary history so that we can assess whether this anemia might be because of the nutritional deficiency. Then consumption of non-food substances, bulky or fatty stools with foul odor to suggest malabsorption syndromes, thorough surgical history with a concentration on abdominal and gastric surgeries. Then we should ask for the family history of hemoglobinopathies, cancers, bleeding disorders, and a particular attention should be given to the medication, because we know that this subset of our population is on multiple medications. So they are under polypharmacy. So we should be asking them what type of medication they might be taking, which might be responsible for this anemia. As for the symptoms of anemia, they are the same as we see in different all other population: weakness, tiredness, lethargy, restless leg, shortness of breath, especially on exertion, chest pain, and reduced exercise tolerance with more severe anemia. Then patient might have a pica, that is desire to eat unusual and non-dietary substances. Mild anemia may otherwise be asymptomatic, so we have to investigate for the milder anemia. In the older patient, we might develop the patient may present with a cardiac failure or angina, intermittent claudication, or even confusion. As far as signs of the anemia is concerned, we know that the most common sign of the anemia is the pallor of the mucous membrane, or the nail bed or the palmar creases, and this pallor of these locations suggests a hemoglobin of less than 9. We can have a petechiae when the patient is a pancytopenia along with the thrombocytopenia and vasculitis. We can have a dermatitis herpetiformis. We can see the colonychia, pallor of the conjunctiva, box cast or the sausaging of the retinal vein, suggestive of hyperviscosity, which can be seen in myelofibrosis. Then we can have jaundice, which suggests the hemolytic anemias, lymphadenopathy, suggestive of lymphoma or leukemia, glossitis, that is the inflammation of the tongue, and cheilitis, and which can be seen with the iron and folate deficiency, patient with alcoholism, and pernicious anemia. So, how to investigate or how to start a workup of a patient of anemia? First and foremost thing is the amongst the lab tests is the CBC, which is the most common, most widely, and most preferred investigation to assess a patient of anemia. So, on the CBC, what we need to see: RBC count, particularly for the hemoglobin, then the red blood cell indices like the MCB, MCH, MCHC, then the WBC count, any nuclear or segmentation of neutrophils, platelet count, and the morphology of the cell size, hemoglobin, anisocytosis, poikilocytosis, and polychromasia. Then second, we need to assess the reticulocyte count, that is percentage of reticulocyte count, absolute reticulocyte count, production index, and reticulocyte hemoglobin content. Then the iron studies like serum iron, TIBC, serum ferritin, and marrow iron stains. The- if the patient is not being diagnosed at this level, then we can go for a bone marrow examination. We do a bone marrow aspirate, wherein we can see the iron stains, the cell morphology, and we can even go for a biopsy to assess the cellularity. On the peripheral blood film, we can have a fair idea about the cause of the anemia with the if we find these particularly or the specific types of cells like the bite cells for the G6PD deficiency, target cells, schistocytes, acanthocytes. So they give a fair idea that this might be cause of this anemia. How to evaluate a patient for hemolytic anemia? Confirm the presence of hemolysis with the help of elevated LDH, corrected reticulocyte count, elevated indirect bilirubin, and decrease or low hepatoglobin. Then we can differentiate whether it is extravascular or intravascular hemolysis. In the extravascular hemolysis, we'll have a spherocytes, urine hemocytokine, and urine hemoglobin will be negative. Where in the intravascular hemolysis, we'll have the urine hemocytokine and urine hemoglobin elevated. How to differentiate the different causes of anemia? So, hemolysis during phlebotomy and significant hemodilation due to large volume fluid resuscitation may lead to falsely low red cell count. We should be assessing that the patient might not have gone the IV fluid therapy or the large volume fluid therapy. If the patients have acute blood loss from maybe trauma, Anemia may not be immediately present on lab testing, as the fluid shift have not had time to occur to normalize the circulating volume. So, thus, the dilating the number of red blood cells remaining. When it comes to the anemia of chronic disease, consider renal failure, underlying malignancies, and autoimmune conditions. For the bone marrow infiltration, we should consider a patient with weight loss and fatigue. Macrocytic anemia with B12 and folate deficiency, we should consider in patient with paresthesias, vegans, or in patient with recent gastric bypass surgeries, so like the bariatric surgeries. Hemolytic anemia, we should consider in all patients with jaundice, dark urine, always question the recent use of medication. And acute upper or lower GI bleed, we should ask for trauma, carcinoma, peptic ulcer disease, or use of NSAID, because like this population is because of the osteoarthritis, because of the low back pain, multiple pains, they might be taking chronic NSAID therapy for that pain. So, differentiating anemia of chronic disease from iron deficiency is the main hematological disorder to consider the differential diagnosis of anemia. IDA and anemia of chronic disease are accompanied by a low serum iron level. The TIBC tends to be increased when iron stores are diminished and decreased when they are elevated. So, in anemia of chronic disease, the TIBC is usually below normal, and whereas it is not the case in iron deficiency anemia. So, and we can also differentiate anemia on the basis of this CBC when we just look for the MCV. If MCV is less than 80, that is microcytic, and that suggests iron deficiency, anemia of chronic disease, thalassemias, sideroblastic anemias, and lead poisoning. When the MCV is between 80 to 100, that is normocytic. It can be hemolytic, it can be non-hemolytic. In hemolytic, it can be intrinsic, like a hereditary spherocytosis, PNH, G6PD deficiency, pyruvate kinase deficiency, sickle cell anemia. And in extrinsic cause, it can be microangiopathic, macroangiopathic, or even autoimmune hemolytic anemia. And even the normocytic anemia can be present in non-hemolytic, like the iron deficiency, aplastic anemia, or chronic kidney disease. In macrocytic anemia, it is megaloblastic, can be a non-megaloblastic. So if the MCV is more than 100, it is maybe the cause of the vitamin B12 and folate deficiency, copper deficiency, and drug induced. In non-megaloblastic, it can be alcoholic use, liver disease, or even some syndromes. And if we are assessing a patient for the iron deficiency, we can differentiate on the basis of the serum ferritin level. If the serum ferritin is less than 50, it is confirmed IDA. We should search for underlying cause, and we should correct with the oral iron therapy and or the IV iron therapy. If the serum ferritin is between 50 to 100 and or the uh, transfusion saturation is less than 20, possibly it is IDA. If the serum ferritin is more than 100, IDA is unlikely. We should identify some other cause like the CKD, MDS, or hemolysis. So we should, if the patient has a serum ferritin between 50 to 100 or even more than 100, we should evaluate for the hepcidin level. If it is very low or undetectable, if it is inappropriately low or high. So if the hepcidin level is high, we should think that there is a block of the duodenal iron absorption, and this type of patient will not respond to the oral iron therapy. They need simplified IV iron therapy, or even a one shot of IV iron therapy will be helpful for such type of patients. For differentiating the patients from the microcytic and normocytic anemia, so like if the patients of the microcytic or normocytic anemia are suspected, we should assess for the serum ferritin level. If it is low, it is iron deficiency. If it is mid-range, determine the serum transferrin receptor ferritin index. And if it is elevated, consider congenital hemoglobinopathies. So if the serum transferrin receptor index is less than 1.5, we should assess for GFR. If it is less than 60, patient is CKD. If it is more than 60, we should level it as unexplained anemia or other chronic disease. If this index is more than 1.5, it is again iron deficiency. We can also differentiate the macrocytic anemia, like if the MCV is more than 100, we should see for the peripheral blood smear and reticulocyte count. If there is abnormal peripheral blood smears, consider myelodysplastic syndromes, malignancies, or the bone marrow biopsy. We can go for a bone marrow biopsy. If there is no abnormal peripheral blood smear and the reticulocyte index is less than 2, if it is less than 2, we should consider vitamin B12 and folate levels. If the vitamin B12 level are less than 100, it is vitamin B12 deficiency. If it is vitamin B12 or folate levels are borderline low, we can consider like methylmalonic acid and homocysteine levels, and on the basis of that, we can consider that it is vitamin B12 deficiency or folate. If the vitamin B12 and folate levels are normal, consider it may be drug effect, maybe alcoholism, maybe liver disease, or even maybe hypothyroidism. If the reticulocyte index is less than 2%, it is not less than 2%, then we should consider lactic dehydrogenase, indirect bilirubin level, or heptoglobin level. And if it is high, that means it is hemolysis. And if it is there normal, then it may be because of recent blood loss and the hyperesplenism. As far as the management of anemia is concerned, so like now we have seen a patient of anemia, we have diagnosed a patient of anemia on the basis of symptom and signs. We have seen the various differential diagnosis that it may be because of, like, we have made the diagnosis that this anemia may be because of nutrition, that is the iron deficiency, or vitamin B12 or folic acid deficiency, whether it is because of acute blood loss, maybe because of the chronic inflammation, or maybe because of some other comorbidities like CKD. So as far as management, the management of the anemia is dependent on the cause of the anemia. So now we have find out the cause of anemia. So if it is because of the acute blood loss, we should correct it with the cross match packed red blood cells, and we should keep the maintaining the hemoglobin of more than 7 in a majority of patients, and those with cardiovascular disease require a higher hemoglobin level of more than 8. So the anemia blood loss, so like the management of anemia will depend on the cause of the blood loss. If the anemia is due to nutritional deficiency, particularly the iron or vitamin B12 and folate deficiency, so for correcting the patient with the iron deficiency anemia, we should calculate the total body iron deficit, which can be calculated on the basis of this Ganjani formula, where total iron dose is calculated on the basis of the actual body weight multiplied by 15 minus actual hemoglobin into 2.4 plus iron stores. So oral, and we can correct if the patient is not having any GI intolerance, or like patient can tolerate iron. We can correct with the oral supplementation, but the dose depends on the patient's age, calculated iron deficit, the rate of correction required, and the ability to tolerate side effects. Traditional dose of ferrous sulfate 25 milligram, wherein the 65 milligram of elemental iron can be given once, twice, or thrice a day, depend on the patient tolerance. And we can even go for a lower dose to reduce the side effects, or improve the tolerance of the patient. To promote absorption, when we are thinking of oral iron, patients should avoid tea and coffee and may take vitamin C with the iron pills. And the hemoglobin level usually normalizes when on the oral therapy in 6 to 8 weeks, with an increase in the reticulocyte count in just 7 to 10 days. If patient cannot tolerate orally, of the patient there is a requirement of that we should go for IV iron therapy. And patients with acute and ongoing blood loss, or patient with intolerable side effects, we can go for IV iron therapy. And the different IV irons available: iron dextrose, ferric gluconate, iron sucrose, and ferric carboxymaltose. Iron sucrose is very commonly used in the practice for the correcting the iron stores in the form of IV iron therapy. And if you're suspecting the anemia due to defects in the bone marrow and stem cells, like the plastic anemia, they require bone marrow transplantation. If the anemia is due to chronic disease, in the setting of the renal failure, they respond to erythropoietin. In the autoimmune and rheumatological conditions causing anemia, require treatment of underlying disease, and they don't respond to the iron therapy is of no benefit in these type of patients. They might benefit with the help of some erythropoietin therapy, and the doses is 50 to 100 units per kg 3 times a week, or depending on the patient's level of anemia. And we can sometimes you can give them benefit with the erythropoietin therapy for the patients who are having a chronic anemia because of the chronic condition. If there is anemia due to increased red blood cell destruction, hemolytic anemia caused by faulty mechanisms will need replacement. Hemolytic due to medications require the removal of the offending drug. Persistent hemolytic anemia requires splenectomy. Hemoglobinopathies such as sickle anemia requires blood transfusions, exchange transfusions, and even hydroxyurea to decrease the incidence of sickling. And DIC, which is characterized as uncontrolled coagulation and thrombosis, requires the removal of offending stimulus. Patients with life-threatening bleeding require the use of antifibrinolytic agents. So to summarize, like to evaluate and the management of anemia in the elderly, first foremost we should confirm the diagnosis whether this hemoglobin is low. If it is less than 12 in females, if it is less than 13 in males, yes, this is anemia. And then we should consider whether the evaluation is necessary. So first we should assess for the iron states, and if the iron stores are good, then we should consider the different differential diagnosis. But if the iron stores are low, first correct the iron deficiency. And if patient tolerate, we can go for oral IV oral therapy. If patient doesn't tolerate oral therapy, we can think of IV iron. If the iron stores are like in the mid range, so we should rule out first the iron deficiency. If it is not iron deficiency, then we should assess the serum creatinine and GFR. If GFR is less than 60, this anemia may be chronic disease. We can refer to the nephrologist, and then he'll take care of that. If the GFR is more than 60, we should consider vitamin B12 and folic acid deficiency, and we should assess the CBC. On the basis of that, we can think that whether the patient will need the erythropoietin therapy, and if the patient is seems to be the atypical cells, or like from the bone marrow examination we find that there is this might be a myelodysplastic syndrome, we should refer to the hematologist. So, to summarize, anemia affects a substantial fraction of the elderly population, representing a public health problem that is predicted to further increase in coming years because of the demographic drive and the increase in the expectancy of the age. Being typically mild, many of times it may be mild, but it is falsely perceived as a minor problem, particularly in the elderly, but it can be a comorbidity. The elderly population might have different signs and symptoms which might not be attributed directly to the anemia, but they might be like the effort, the intolerance, that they might be having generalized weakness, lethargy. So we should not take it mildly. Etiology of anemia at older age is complex and ranges from bone marrow failure syndromes to the chronic disease, from nutrition deficiencies to the inflammatory processes, and we should assess them very clearly so that we can correct them and we can provide good benefit to our elderly population. Management of anemias at older age depends on the severity of anemia, underlying conditions, and patient-related factors, including comorbidity. Even a mild anemia may substantially affect physical and cognitive capacities and quality of life. So, we should be very cautious while assessing a patient of the genetic population. We should assess the anemia, we should find out the cause, and then we should apply the treatment on the basis of that. Because, like, it's not necessary that every anemia is just the iron deficiency, but we should be considering that whether it is nutritional or maybe because of other causes. Thank you very much for the patience hearing.
Thank you, Dr. Navneet. Very pleasantly described, very wonderfully described. You've talked about the complexity of causation and also the complex clinical presentations that anemia can have in the elderly. And you've also brought out the utility and the urgency of management. So we should not ignore, we must manage this condition. And if you have a senior citizen presenting to you in your clinic, your responsibility actually becomes double fold. You have to take care of that patient's health. Even otherwise, you would do it out of respect, out of gratitude for them having contributed so much to society. But because the chances of errors are also more, you have to be more cautious. Dr. Navneet, many questions coming up your way. So, Dr. Vinay Desai asks a question about statins. Uh, we need to intensify statins to target levels, right? So, what is the maximum dose of atorvastatin or rosuvastatin that you use in practice?
It depends basically, like whether the patient needs a intensive therapy or moderate therapy. So depending on the if the patient is a ASCVD, if patient is already existing coronary artery disease, like patient is CAD along with the PTCA and patient has CAVG done, yes, we need an intensive therapy. Even up to 40 milligrams we use. But if the patient is not having much of risk factors, patient is just for the having hyperlipidemia, we can go for even 10 milligrams. So depending on the patient risk factors, depending on the patient's presence of comorbidities, the intensification of the statin therapy is decided.
If the cardiologist or cardiothoracic surgeon has written atorvastatin 80 milligram or rosuvastatin 40, there must be a reason for that. So please encourage your patient to continue. If, however, you are managing in the OPD, like Dr. Navneet or myself or you, all of us are OPD physicians, then maybe we will start with 10 or 20 milligram, 10 rosuvastatin, 20 atorva, and we will up titrate as required. But if someone else has started a higher dose, please try to continue that. Dr. Navneet, Dr. Vinay continues with this question and he says, supposing patient is, let us say, taking atorvastatin 20 milligram. Patient has not reached LDL target of 70. Patient has diabetes. Then does it make sense to increase atorva to 40? Or would you want to add ezetimibe or bempedoic acid? Or are both of the above options correct?
Both can be done. We can increase the dose of atorvastatin or rosuvastatin. But now we have, since we are not having the newer medication, but now you have medication like bempedoic acid, which can be added to have a benefit, because the ultimate goal is to achieve the target. We have to achieve a target of less than 70 of LDL. And if you're not achieving a target of LDL with a single drug, yes, definitely we can add a second drug. Because like many of times what happens when we go to a higher dose like 80 milligram of atorvastatin or 40 milligram of rosuvastatin, patient might not tolerate, patient might have the muscle aches or like the myopathy. So in that case, if we need to bring a target depending on the patient's profile, yes, we can add newer drugs.
There are questions on anemia from Dr. Javed Iqbal Khan from Srinagar. We acknowledge them and let us take them in a minute. One more question on diabetes. Let's take from Dr. Vinay Desai. He describes a patient to you, Dr. Saab. Weight 70 kg, adult patient, on basal bolus therapy, quite high dose. Basal 40 units. Hmm? Bolus, I think is written opposite here. Bolus 16, 14, 14. Right? Before lunch was 60. Patient is asymptomatic. So if the before lunch glucose is 60, which dose should we reduce?
This is the the bolus dose of lunch we should reduce, because like before lunch was 60, so we should reduce the dose of bolus at the lunch. But mind it, we should not completely omit the dose. Many of times what patient used to do, like when they found 60, they completely omit the dose and they comes out like, doctor, my sugars has increased after lunch. So it should be reduction of the dose, not the omission of dose.
Yeah.
But yes, you find the like the normal or the like 60s before lunch, we should reduce the bolus dose of lunch.
So tomorrow, the next day, we will reduce the breakfast dose also from 16 to 12, maybe.
And for the next
Right.
day, yes, because like the fasting, the breakfast dose has reduced it to 60, so we should reduce the dose of breakfast.
Yeah. But that we will do tomorrow. And today,
Yes.
maybe instead of 14 for lunch, we might want to give 7 for lunch, 7 or 8.
Yeah.
Dr. Khan has a question. How frequently do you see anemia with worm infestation, with Ascaris infestation?
It's very common, particularly because like I practice in Gwalior, we serve the population of the rural areas, those who are working in the farms, in the agricultural land. So the chances of worm infestations are very common, particularly in the population of the rural population. So we come across very commonly, and even patient comes with the multiple other symptoms. Not only the anemia, they come with the chronic pain abdomen, and even some patient they say that they give the history that I passes the worms in the stools.
And have you come across mixed infestations as well? Different worms, or and is there a separate treatment for all of them, or do we have blanket treatment with albendazole or with ivermectin?
Usually we give with the because like we don't go for a stool test whenever patient comes to us in OPD. It is just a clinical scenario that patient comes and they say that, and or we might suspect that patient might be having a worm infestation. We usually give a combination of albendazole plus ivermectin, because many of times we don't go for a stool examination, and majority of patients they get symptomatically better with that, and we ask them to repeat it. But if the patient is not getting rid of it, then definitely we go for a examination and to find out the cause, and then we can treat on the basis of that.
Dr. Javed shares a very good clinical pearl. Thank you, Dr. for sharing this. Wherever there is no obvious cause of anemia, then you must do an endoscopy.
Yes.
In the elderly, it is even more important. Both upper and lower GI endoscopy should be done, because you never know where you might find a lesion.
Yes.
But now there are some cases, even after doing the endoscopy, you may not find a cause. So then you treat for nutritional anemia. But now his question is capsule endoscopy. Do you have any experience with that?
In fact,
Detecting invisible blood losses from the gut.
yes, the capsule endoscopy. In fact, like now we are having the more and more technology helping us in diagnosing the various diseases. Initially, we were not having this opportunity to get the capsule endoscopy, but yes, capsule endoscopy helps us to find out even the smallest lesion throughout the gut, because like upper GI and lower GI we can see only this some parts, not the entire GI tract. So with the capsule endoscopy, yes, it is available in many of the cities. Even in my city, one of my friend is doing capsule endoscopy, and with that we can diagnose the lesion correctly.
The Dr. Javed, actually, तो उर्दू में है कि आपने हमारे मुंह की बात छीन ली. So actually, Dr. Javed always preempts Iron Talks, because next week we will be having Dr. Pavan Rawal from Gurgaon. He's a gastroenterologist, and he will be speaking to us about all these things, about anemia and the gut. So thank you, Dr. Javed. Thank you for preempting and promoting Iron Talks. We have one more question, and this is about reactive hypoglycemia or postprandial hypoglycemia. So, Dr. Navneet, how common is this in your practice, and do you counsel your patients that it is a sign of pre-diabetes?
Yes, many of the patient in our clinical practice they come like my sugars are otherwise normal, but it goes down after the meals, and I'm not diabetic. My A1C is 5.9 or 5.8. So these patients, those who are having underlying insulin resistance, they are obese, they are having insulin resistance, and these patients like initially they have this reactive hypoglycemia after the meals, and then it is normal. And what they do to avoid this hypoglycemia, they eat more, and they eat more, they get more insulin release, and they get more hypoglycemia. So in such type of patient, we usually educate them. We try to make them understand that they should go for a small frequent meals instead of going for a larger meal, so that they'll have a lesser insulin release, lesser reactive hypoglycemia after 2 hours of that meal. So frequent incident, like what patient they used to, like they suspect that hypoglycemia, they take more of gulab jamun, more of mitai, and they have more of hypoglycemia. It should not be
So
like.
the treatment, Dr. Vinay, is small frequent meals or a 6+6 meal pattern or 3+3 meal pattern, three major, three minor, with less of simple carbohydrates, because simple carbohydrates will increase insulin secretion and that will worsen the reactive hypo. And maybe you can increase the protein intake. Even fat will be safer. And if patient wants to take carbohydrates, they should limit themselves only to complex carbohydrates. Some very funny things in diet you will notice. So we all say that potato is not good for people with diabetes. But if somebody were to ask you sweet potato, you would say that is even worse. But that is wrong. Potato has 140 calories. Sweet potato has 126 only. And sweet potato has 3 times the amount of fiber as compared to white potato. So actually, you can tell these patients to take sweet potato to fill their stomach. And another thing is that in Indian cuisine, potato is cooked in many ways, including frying. But sweet potato will always be either it will be roasted or it will be steamed or boiled. So no extra oil or ghee will be added. So these are some simple tricks to use in the OPD. And your patient will actually go back happy. So patient will go back and tell his entire family, that doctor is very intelligent. He explained to me why I can take sweet potato in moderation. And rest assured, Dr. Javed and Dr. Vinay, that entire community who learns about sweet potato from that patient, they will come and show you only for diabetes. They will not go and show anybody else. Any other drug that we can use to treat reactive hypo, like acarbose?
Yeah, we can basically, like, we can reduce the, if we can reduce the carb absorption with the help of AGIs, so that will have a less stimulation to the release of insulin. Will be having a less chances of hypoglycemia.
Out of all the drugs that we have available in diabetes, there are so many drugs. You learn so much about them in CMEs. But there is one drug that covers the entire gamut of dysglycemia. That is acarbose. It can be used in reactive hypoglycemia. It is approved for use in type 1 diabetes, in type 2 diabetes. It has been tried very well in pre-diabetes. And in fact, the Stop NIDM trial showed that if you use it in pre-diabetes, you can prevent cardiovascular complications. And if you are, really desperate to use a drug, an oral drug in GDM, in gestational diabetes, apart from metformin, you can use acarbose because it will not be absorbed from the gut. Similarly, for women in lactation, many times they will listen to you and they will take insulin during pregnancy, but after delivery, then they want freedom from injections. So then also you can try acarbose in lactation period. Of course, explain to the patient all the pluses, minuses. While we are speaking of pregnancy, metformin had already been approved in India for use in pregnancy, but this week it has been approved in Europe as well. So this is an example where Indian expertise, Indian experience has led Europe in terms of approving this drug. So Dr. Navneet, it's been great having you. On Iron Talks, we meet our colleagues from across the country. We meet general physicians, internists, gynecologists. So what would you like to say to them before we conclude and before we hand over to Mr. Anand Basu from FDC for the both of things?
My final words will be, like, it is a good platform to interact with you all across the, like, the doctors, my colleagues, the fraternity across the country, and this platform provides us an opportunity to have our questions where we can ask them freely, to discuss them freely, which we come across in our day-to-day practice. As far as my today's talk is concerned, my the say concluding remark will be that the anemia is very common. We know that across the country, anemia is a very common challenge across, like, even in the females, they are very very particular. So the females, we focus on the anemia in the females, we focus on the anemia in children's, but in the elderly population there have been many studies where we have found that anemia might be a cause of the heart failure. Anemia might be a cause of the patients having breathlessness, or even the patients are having lethargy, generalized weakness. Many patients, they come to our OPD, they are diabetic, and they come and say, डॉक्टर साहब वीकनेस बहुत लगती है, थकान बहुत रहती है, and we try to write some multivitamins, some antioxidant, or even vitamin D. But sometimes, and many of times, we forget that this might be because of the subclinical, not very very severe anemia, like less than 9. It may be 10, 10.5, or 11, but patient might be having this type of symptoms, maybe because of this milder anemia. So we should be assessing not only the elderly, but every diabetic should be assessed for anemia, so that we can correct it, and we can provide the benefit in this type of problems.
Thanks. And if you worry about GI tolerance, then liposomal iron or nano iron is a very good drug preparation, iron preparation to use. Very safe, very effective, and very well tolerated by our elderly citizens. With this,
Ji.
Dr. Nunit, thanks you once again. Thanks, Laksa.
Thank you, sir.
And we
Thank
invite
you.
Mr. Basu from FDC for the vote of thanks.
Sir, I take the cue from the ongoing conversation, and I also add that instead, means in this platform, not only the different fraternities of the medical science is coming and joining and helping us in terms of the iron pool and iron talks, but also while I was listening to Navneet Agarwal sir, that the way he practices in the rural as well as the urban areas of Madhya Pradesh and especially in Gwalior, I was looking into the challenges he faces from the rural population and the typical behavior and the pattern he follows, and which is quite different from the eastern or the western or the southern population, which also enriches the platforms pool understanding and pool information and pool experiences, sir. That's the beauty of Iron Talks with Dr. Sanjay Kalra. With this, and also see that one of the best endocrinologists and diabetologists from the Bundelkhand area, I know Dr. Agarwal. I would also love him to be part of our ongoing journey with 52 weeks diabetes essential with Dr. Sanjay Kalra. And I also saw that one more beautiful thing, that's a lot of lipid-like questions which has come, which we know that this has been coming from the Monday's program of Dr. Jocelyn's Om Agrawal sir. And I'm very happy to see that Indian doctors are practicing the same levels with the same numbers which we've been talking on the last Monday, sir. With this, I sincerely thank Navneet Agrawal, sir, and we love him to be there next time, very soon, with the next programs with Dr. Sanjay Kalra, sir. And I'm for Sanjay Kalra, sir. I know he's been traveling and he found a quiet place in, I can see here he's been sitting in the,
Yes.
exit gates of GMR Hyderabad International Airport. He takes a lot of efforts to continue this 9 p.m. program, which has been running for last 3 years now. With this, sir, I thank everyone and goodbye and good Jai Hind, sir.
Thank you.
Jai
Thank
Hind.
you so much, sir. Thank you. It is nice to share a dice with you. Thank you.
Yes,
Thank
sir.
you, Mr. Basu. Thank you
Yes, sir.
taking me on the board. Thank you.